I am Jacques Duranteau, chair of the Department of Anesthesia and Intensive Care, University Hospital of Paris-Saclay. So the fluid management of trauma patient is part of the damage control resuscitation. The goal of the damage control resuscitation is to provide only intervention necessary to control hemorrhage, to focus on reestablishing a survival physiologic status. The goal is to limit deleterious effect of hemodynamic instability, coagulopathy, hypothermia, and acidosis. And it's very important that we have to be focused on the fact that we have to stop the bleeding as soon as possible. So the three pillars of the fluid resuscitation in trauma patient are: first, the permissive hypotension; second, the fact that we will give a low volume of crystalloid; and finally, the fact that we are able to give very earlier transfusion of blood product. About permissive hypotension, the recommendation are to target a systolic arterial pressure from 80 to 90 and a mean arterial pressure from 50 to 60 until the bleeding has been stopped. It is obvious that if we have to deal with a trauma brain injury, we have to increase the mean arterial pressure to be sure that we have a good perfusion, cerebral perfusion pressure, and we have to reach a mean arterial pressure equal or greater to 80 millimeters of mercury. About low volume of crystalloid. Low volume of crystalloid is not no fluid resuscitation because we have to deal with an hemorrhagic shock and we have to give fluid to our patient. But fluid resuscitation must be limited to what is strictly necessary to achieve recommended arterial pressure target. So the best way to do is to perform successive bolus and to look at the response in terms of arterial pressure to be sure to give only the necessary quantity of crystalloid. Fluid resuscitation alone is different than fluid resuscitation and vasopressor. So we know that if we add a vasopressor, it will induce arterial, it will increase the arterial tone, but it will also increase the venous tone. And through this increase of venous tone, increase the venous return and increase the cardiac output by decreasing the unstressed blood volume. So in my unit, we introduce very quickly the vasopressor, norepinephrine, when we observe no response to fluid resuscitation. Another interesting point is that vasopressor could have other effect than the vascular effect. And in this study, where it's a randomized, double-blind, placebo-controlled, single-center study, they test the effect of low dose of vasopressin. And you can see that this low dose of vasopressin was able to decrease the quantity of red blood cells, FFP, platelet, and fibrinogen, which was necessary for the resuscitation of this patient. So clearly, an hemostasis potential effect of low dose of vasopressin. So a very interesting effect that we have to take in account. So, which fluid do we have to use? The first choice is the isotonic crystalloid solution. The use of colloid must be restricted because they can induce adverse effect on hemostasis and on kidney function. We have to consider balanced electrolyte solution because we know that the sodium chloride 0.9% is capable to induce acidosis and is capable to decrease the kidney blood flow and have deleterious effect on the kidney function. But we need more study to analyze this in trauma patient. It is why we design this study where it's an ongoing study, we compare plasmalit versus saline 0.9% in a trauma population, looking at the effect at the level of the kidney function. What about early transfusion of blood product? The recommendation recommend to give plasma and red blood cell in a plasma red blood cell ratio of at least 1.2. So it's a high ratio of plasma red blood cells. And this recent study, it's a retrospective study where they analyze a cohort, a French trauma registry cohort, and they clearly show that with a high ratio FFP to plasma red blood cells here greater than 1.5, there is clearly a decrease in mortality in this patient. So we have to use this high level of ratio, and clearly during the past years, there is a shift from a crystalloid strategy to a blood component strategy, where we give a very earlier red blood cells with a high ratio of FFP red blood cells. So, in conclusion, the three pillars of the fluid resuscitation in trauma patient are the fact that we have to respect permissive hypertension. The second point is to limit the quantity of crystalloids that we give to our patient. And the third point is to have a clear strategy of aggressive treatment of the coagulopathy by giving as fast as possible red blood cells and FFP and acid tranexamic and fibrinogen to be able to prevent the best we can the coagulopathy. Thanks a lot.